Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs. Welcome everyone to today's program, Frankly Speaking About Bladder Cancer. I'm Katie Armsby with Cancer Support Community Atlanta. If this is your first time joining a Cancer Support Community Atlanta program, we welcome you. We invite you to visit our website that's listed there, cscatlanta.org, where you can see all the virtual and in-person oncology programs that we offer. We have some great support groups led by licensed mental health professionals, some stress reduction classes like yoga, tai chi, chair yoga. We also have a monthly nutrition seminar that's facilitated by an oncology dietitian with Northside Hospital Cancer Institute. And we also have just recently introduced a newly diagnosed Nutrition 101 program. So we invite you to attend those programs and also check out education programs like these. So again, we invite you to visit that website, cscatlanta.org, where you can see a complete schedule of today's event or of the events that we offer. Today's program will be recorded and sent out to everyone who registered via email. So if you know anybody who missed the live presentation, you can find a recording of the program in your inbox, and it'll also be available on our video library. I'm excited to present today's program moderator, Dr. Chowdhary. Dr. Chowdhary is a board-certified hematologist and medical oncologist with experience treating a wide variety of disorders. She completed training medical education at the New York University School of Medicine, and her internal medicine training was at the New York University Langone Medical Center. Dr. Chowdhary completed her hematology and oncology fellowship at Northwestern University in Chicago. She has a special interest in benign hematology as well as lung, breast, GU, and gastrointestinal disorders. Dr. Chowdhary practices with Atlanta Cancer Care at the Cumming location. So with that, welcome Dr. Chowdhary, and I'm going to pass it off to you.
Thank you, Katie. So it's a pleasure being here, and I am happy to introduce our program facilitator today, Dr. Mellis. So Dr. Mellis graduated from Emory University. He received his MD at Louisiana State University in New Orleans and went on to complete his surgical internship and urology residency at University of Oklahoma, where he then went on to do a fellowship in urologic oncology and robotic surgery. He's currently practicing at Georgia Urology, seeing patients both in Johns Creek as well as Cumming. And when he's not busy taking care of his patients, he's spending time with his family, traveling, and enjoys playing basketball. So welcome, Dr. Mellis.
Thank you for having me. Can everyone hear me? All right. So we're going to go ahead and thank you for spending lunch with us. Going to go ahead and, nitty gritty, first of all, I have nothing to facilitate, no financial relationships or affiliations to disclose. So everything you hear is my own opinion and not that's it. So what are we doing today? We're going to talk about bladder cancer, understand some treatment options, and what can you as a patient do? Prepare for visits, second opinions, clinical trials, and then obviously, it kind of takes a community. Just you don't go through potential bladder cancer yourself. So how do those who care for you care for themselves? So let's get right into it. The plan will be about a 30 to 40 minute talk. Give everyone about 10 to 15 minutes for questions. I'll have Dr. Chowdhary hop back in on the Q&A part, see if she can, with her medical oncology expertise, help me out with some of these great questions. So let's start with understanding bladder cancer. There we go. And there are some terms you're going to need to know or understand when it comes to bladder cancer. Staging, that's very important when it comes to bladder cancer. There's a big dichotomy there we'll get to in just a second. understanding what options there are for bladder cancer, and then understanding, obviously, that there are side effects to treatment. So, understanding bladder cancer. Cancer in general occurs when the cells in the bladder grow and divide uncontrollably. Cancer may occur because a single cell or cells collect too many genetic errors. And then as these cells grow and divide, they'll begin to form a tumor. I will point here to the bladder layers here. This is kind of an important distinction when it comes to bladder cancer. The muscle is kind of the big deal. So the bladder lining itself has two inner linings. This sort of most superficial layer you see in blue, and then this additional layer, which we as urologists commonly call the lamina propria. These are whenever tumors do occur, they occur you can see them here, sort of this area here, and then they also do kind of grow depth-wise into the muscle and then the fat around the bladder. When it comes to staging, it's going to be kind of an important difference between what we call non-muscle invasive and muscle invasive bladder cancer. Some terms to know, and this is just broadly speaking with bladder cancer. Chemotherapy, that would be kind of Dr. Chowdhary's wheelhouse. Targeted therapy, what we could do to sort of target the bladder cancer itself. Radiation, as you can imagine, high amounts of focused energy that could be used in some bladder cancers. Immunotherapy, where we stimulate one's own immune system to help fight the cancer. Maintenance therapy, which we can talk about when it comes to potentially what we call BCG therapy. Clinical trials, which are also very important in helping advance future treatments. And the term cystectomy, which we'll be using throughout the procedure, means a complete removal of the bladder. That is something we do see in folks who do have muscle, or would be a standard a treatment option for patients with muscle invasive bladder cancer. A urostomy is a way to drain the urine, and we'll get more into that in just a few slides, but that is essentially where we have urine drain into a opening or a bag in some instances. If you think of patients who've had colon surgery and they have a colostomy, this is kind of the urinary of it. And then PDL1 biomarker, once again, more towards the immunotherapy, which we can let Dr. Chowdhary comment in on the Q&A session. So bladder cancer, massive teams, medical and radiation oncologists, urologists like myself. And then in addition to the physicians, we have wound nurses, urology nurses, love our nurses, in some instances, and more advanced disease and more aggressive disease patients to help with comfort care and palliative care, physical therapists, dietitians, social workers, and patient navigators. A few questions. I'll back up one. Why is cancer staging necessary? It determines, determines how aggressive one needs to be for removing or how aggressive these treatments need to be. If you have a very small, non-aggressive tumor, which is early stage, then we don't necessarily have to be aggressive in saying removing the bladder. A lot of times, we can manage these with surveillance and taking a look at inside the bladder every few months. Can the stage of bladder cancer change over time? Yes, it can, and that's kind of the importance of follow-up and keeping close tabs on the cancer and making sure you are on top of all treatments. Absolutely, it can go from more aggressive to not less aggressive. And what diagnostic tests? Imaging. Typically, we do imaging in patients with bladder cancer. Usually, it involves some sort of cross-sectional imaging like a CT or an MRI of the kidneys and the ureters to make sure everything looks good, make sure there's no spread of cancer outside the bladder. Blood work, yes, we typically do a battery of blood work in patients with bladder cancer. Usually check blood counts, electrolytes, kidney function, liver function, those types of things. And does the stage of cancer impact treatment options? Yep, sure does, as we talked about just a few seconds ago. So the important distinction in bladder cancer is the difference between non-muscle invasive and non-muscle invasive and muscle invasive. Typically, when the cancer invades the muscle, it pretends to be a more aggressive bladder cancer. What are treatment options for non-muscle invasive bladder? I'm going to back up just a step and let's talk about what's this picture here to the right. And this is kind of how we initially diagnose bladder cancer. And that's usually, there's some sort of symptom. Most oftentimes than not, it's blood in the urine, a term we as physicians call hematuria. A lot of times it doesn't hurt. So you may have blood in your urine and there's nothing, doesn't hurt, doesn't burn, doesn't sting, and it's just there. So absolutely paramount that you seek medical advice. And this procedure here you can see is a cystoscopy, or I guess in this instance, what we call a transurethral resection of the bladder tumor, where we have identified an area of concern, the tumor here, and we are able to use a more rigid scope. This is usually done under anesthesia, where we use sort of a scraping device to scrape the tumor out of the bladder and send it for pathology analysis. I will make a quick comment, not included here, but there is technology that the Northside facility does have. It's pretty much becoming more and more the standard of care. It's called blue light cystoscopy. Typically on standard cystoscopies, it's sort of the bladder background sort of seen as in a white, and then these tumors are seen. I describe it as sort of like cauliflower looking, having sort of finger-like projections. Sometimes smaller, more subtle tumors could be missed on white light cystoscopy. So we've partnered with Northside and Georgia Urology, where we have, if we're going in to resect the tumor, we can inject this dye into a patient's bladder about 45 minutes to an hour prior to procedure. And then the camera we use, which is over here on the resectoscope, the filter can be changed where the background is seen as a blue light, and then the tumor cells can pick up this dye that we inject, and they fluoresce a hot pink. So great technology, actually becoming more and more the standard of care, where we can resect tumors more completely and get better staging. Staging is important because obviously our goal with any type of cancer is to cure the cancer and to leave no evidence of disease, a term we call NED. So, as I mentioned, the big differences is between muscle invasive and non-muscle invasive. Muscle invasive pretends a more aggressive diagnosis. This is stage 0, stage 1 are your non-muscle invasive bladder cancers. Stage 2, 3, 3B, 4A, those are more aggressive disease. And then, unfortunately, what we all try to avoid is diseases that are metastatic, that is spread outside the bladder. Those tend to be, as you can imagine, even more aggressive, and those end up being stage 4 as well. What do we do for muscle invasive bladder cancer? Surgery. now done a lot of ways via robotic approach, where we make small incisions across the body. A procedure called a cystectomy. A cystectomy is a complete removal of the bladder. And then the thought is, well, wait a second, if the place where my urine goes is gone, where does my urine go? We'll get to this in just a second, but there'd be some sort of urinary diversion, whether it is an ostomy or or we can create a new bladder, or what we call continent diversion with using bowel, usually the small bowel, one's ileum, which is the second part of one's bowel, but we also can use pieces of colon to create and fashion new bladders. And then, for there are some, most patients we try to do cystectomies on, but we understand that there are a lot of folks with muscle invasive bladder who either don't want their bladder removed or just can't tolerate the surgery. It's a pretty rough surgery, or I'd say rough, but it is an involved surgery where you're in the hospital for about a week. So if that's the case, then we do have alternatives, chemotherapy, immunotherapy, targeted therapy. I would also say that radiation would be a good point to put here, and usually some sort of combination, what we call trimodal therapy. We use either chemo or immunotherapy, radiation, and then a urologist trying to resect the tumor endoscopically the best he can. And our goals with muscle invasive bladder cancer, obviously, we always try cure, but for metastatic disease, we try to sort of slow the spread of cancer, limit tumor growth, extend life, keep you try to keep you symptom free. Blood in the urine, try to keep that to a minimum. And with anything we try to do is try to keep good quality of life. One of the terms we talked about earlier is maintenance therapy. Once again, staging is important because it does, the idea behind maintenance therapy is it lowers the risk of recurrence. But when we think about it in the non-muscle invasive bladder cancer, we think of maintenance as used to prevent cancer from coming back. And then when we think of maintenance therapy in the metastatic, it's to sort of slow the growth of cancer. So, question: can staging and treatment options change over time? Absolutely. One of the important things about non-muscle invasive bladder cancer is compliance with treatment, looks inside the bladder, maintenance BCG, or other treatment options. Unfortunately, cancer just doesn't play fair, and we try to make sure we keep an eye on it. And if there's a concern for recurrence, we take care of it. Unfortunately, some of these diseases can progress from the non-muscle invasive to the muscle invasive, and unfortunately, some patients with muscle invasive can progress to metastatic. So we do our best to make sure we try to prevent that. And obviously, as we mentioned earlier, the treatment for non-muscle invasive bladder cancer is indeed different from, say, metastatic or muscle invasive bladder cancer. So what can we do, or what can you do as someone potentially affected with bladder cancer? Preparing for visits, second opinions, clinical trials. We'll get all through that. So preparing for appointments. I think it's very important to be your own advocate, right? We want you to ask questions and as a urologist, I feel like the best encounters I have are where it's interactive and people ask questions and ask me is, why are we doing this? What are we doing? What are the side effects? So be your own advocate. Don't be passive. Be an active participant in your care. And I think that'll help you maintain control. Take notes. Bring a friend, bring your loved one, bring your spouse, bring whoever. An extra set of ears is always welcomed. What questions to ask? There, you can see some of those there. these are, what is the goal of treatment? What are we doing? How will I feel? What, I tell patients anytime we do something, we always want to know what the risks are, the benefits, why are we doing it, the complications, what could go wrong, and then the alternatives. Is there something else we could do as well? And then all right. And then what are your goals and values? What's, questions you need to ask is what is important to you? What's important in your life and with your family? Are you getting the support you need from not only your from yourself, or are there other people, kind of going through what I'm going through? And that just underscores the importance of such organizations like the Cancer Support Community with Northside, and I think this is such a great group to see what's important to you. We, as urologists, always, seek a second opinion. If you, I tell my patients before I do any sort of procedures or any sort of surgeries that, you have to be 100% comfortable with what you're doing first, and then secondly, with whom you're doing it. If you don't feel 100% with either of those, then not a bad idea to, hey, let's get a second opinion somewhere else and figure out if this doctor's really covering all his bases. And then finally, clinical trials. If there's something, why do clinical trials? Potentially test new treatments for cancer, find new ways to manage, symptoms and side effects. And then, it gives you, patients in clinical trials usually do have a better understanding of their cancer care and why they're doing it. Folks, when you focus on clinical trials, what clinical trials are available. If you're talking to Dr. Chowdhary or her team, what are the benefits, and am I eligible? Those are all important questions. And obviously, how do I get more information, and how do I enroll if I'm indeed interested? I'm a big advocate for clinical trials. If there's something new, that you can that could potentially be the standard of care years later, and you were there to begin with, and that helps you and it helps fight your cancer, then I'm for it. So moving on to the next part of the talk, sustained by community. So understanding the emotions of cancer, diagnosis, caregiver concerns, and finding support. This is a part we don't really talk about. Sometimes we just talk about, hey, this is what we do. What do we do to get rid of it or get it under control? And then we understand, we're becoming more and more attuned to the part that, there's a cost to this, and more than just physically, there's an emotional cost and a financial cost that folks are going through. And when someone's diagnosed with cancer, you have this sort of challenge of I'm losing control and living with uncertainty and isolation as well, and that's all very common. And I was a healthy person, and all of a sudden I had this diagnosis or this concern. I've kind of lost control, and what do I do to sort of combat that? And obviously, the life after a diagnosis, we have to talk about here: side effects, care plans, emotional wellness. So as I mentioned earlier, bladder cancer is a spectrum of disease. It does have some side effects. I would say the side effects on the first column would be more towards the chemotherapy, sort of more systemic therapy, nausea, neuropathy, fatigue, skin changes, hair loss, cognitive sort of chemo brain, as we call it. The urinary incontinence can occur after an initial, after these types of procedures. Blood in the urine and painful urination can occur after sort of the initial that TURBT, where we resect the tumor. Obviously sexual dysfunction and can occur in some instances of bladder cancer, especially with some diseases like bladder removal or the cystectomy. The hematuria, once again, is the blood in the urine we talked about. And then weight loss and loss of appetite can be seen in more advanced stages as well. Froze on me here. Oh, there we go. So managing long-term and light side effects, I think that is important, where you talk to your physician and his team, his nurses, all those folks we talked about, the nurses and your team, into how we can help keep that where we have a good quality of life. And then other side effects, once again, I think this is more on the systemic therapy, not the initial, say, bladder tumor removal. Physical wellness, eating well and moving and exercising, absolutely. I think this would not only apply for bladder cancer, but sort of all the different types of cancer we work with. Build strength, get nutrients, get out there, protect your bones, achieve a healthy weight. If you have a few extra pounds, try your best to shed them. And I think, movement and exercise, it doesn't have to be, it doesn't have to be running 5 miles. It could be a brisk 30-minute walk in the neighborhood over lunch, or in the office or in the parking lot. Just something to get your mind off of work or life for a few minutes, put in some headphones and just go for a walk. Physical therapy, very important part of our team when it comes to treating patients with bladder cancer. These are the some patients who do have issues with their bladder. We help them work those what we call the pelvic floor, help them strengthen those muscles there. And according to the CER, Cancer Experience Registry, 42% of patients were obviously concerned, especially if you've had a procedure like a bladder removal, as I mentioned, is a pretty involved surgery. We do get physical therapy involved and get you getting that strength back. And obviously that'll help not only you recover better, but help you feel better too. So as we mentioned earlier, we're going to go ahead and just talk about these briefly, but we talked about these, I think, a few minutes ago. A urostomy is sort of what we call an incontinent diversion, where the ureters that drain the urine from your kidney now don't have a bladder to enter. So we take a piece of the small bowel and connect the ureters into one portion of the bowel, and then the other portion, where the bowel being a hollow organ, will be connected to the skin. And then, kind of like a colostomy, you have a urostomy. I would say a good bit of our patients do choose that option. The other option would be, or other couple options are a little more involved. A continent diversion is where the urine collects into sort of a piece of bowel that doesn't just go into an opening or into the skin, where instead of just collects in, say, part of the colon that's just been kind of reshaped to hold urine, and then sort of a long cylindrical tube called a stoma, where one could put a catheter in every few hours to drain the bladder. And then the most involved is a neobladder, where we use a significantly more amount of small intestine to actually fashion a new bladder, and we connect the ureters once again into the bladder, kind of put this neobladder where the bladder was, and then reconnect it to the urethra. And the idea is that albeit not a normal bladder, but the idea is hopefully to retain to where one could function through the penis or through the vagina. changes to the body is as you can imagine, if removing your bladder and potentially having a urostomy or neobladder could definitely have changes to the body. And then obviously chemotherapy and radiation, which Dr. Chowdhary can talk more about the chemotherapy. And then obviously if one has a urostomy or one has a cystectomy with a neobladder, these are surgeries that leave scars and that can definitely affect one's image. So, obviously a lot of these effects can affect intimacy, and it's important to talk about it for survivors and then for partners serving as caregivers. So what can you do about it? So what can you do about it? Obviously, I think the first thing is try to talk to someone. I talk to your immediate support group, or the great thing is we have all these cancer support groups within the Northside system. Definitely a group that we can talk to as well. And then, if you're kind of more want to talk about it one-on-one, then therapists can help as well. Obviously, there are plenty of concerns anytime someone has a potential cancer diagnosis about what happens in the future and risk of anxiety and increased risk of depression. Absolutely. And I'd say the cost of care definitely is, maybe not the first thing you think of, but yeah, it's an absolute something to talk about. And I know that something we see often in our office, and once there's a diagnosis of cancer, it's something that stays with you over a period of years and or hopefully longer, but always a concern to have. And then always plenty of resources available, and plenty of resources available. I know Northside has a ton of resources available to help with cost and such. I've experienced that with my patients. So what do we do when bladder cancer recurs or progresses? According to the cancer registry, 56% of patients, rightfully so, are worried about coming back or progression. We try as physicians to sort of calm those fears, but what you can do is talk to your physician and say, hey, what should I be concerned about? What should I be concerned about if there's a recurrence? What are the reasons I should call you back, or call you and be seen sooner than say 6 months or a year? That I think is patient education, and that's paramount. And then always have a plan. Last point here, anxiety. I mean, that's actually very common. Hey, my scan to see if there's no cancer coming back is coming up. I'm worried. It's very, very reasonable to have that. And yeah, I mean, I think this is important. Kind of figure out, talking to your physician. If I have bladder cancer, well, doc, how often do I have to do a cystoscopy or a BCG treatment or immunotherapy, or when are scans due? I think getting a sort of a care plan of what's going on is absolutely paramount, and needed moving forward. And then, as we mentioned earlier, this is a multidisciplinary approach. This may not just be a urologist. This will be nurses and medical oncology and potentially radiation oncology involved in your care. Unfortunately, there are some instances where disease is metastatic, or there is aggressive disease or progression of disease, where palliative care specialists are recommended or ordered for patients who have bladder cancer, and they're important. They help improve quality of life and can help with your care during cancer treatment. Then finally, let's talk about the people who take care of those who are dealing with potential cancer, caring for caregivers. For those who are caregivers, you can imagine taking care of yourself is important, right? So you can't help someone else unless you take care of yourself. And if that means, if you have a spouse diagnosed with bladder cancer or any type of cancer, it's definitely affects you too, right? And or would affect you. And in order to help your partner, your spouse affected with bladder cancer, you got to take care of yourself, and it's okay to ask for help. So the caregiver has, a lot on their plate, in addition to providing emotional support, accompanying patients to medical appointments, helped decide the next step in their care, provided transportation, coordinated medical care, and helped manage finance. So kind of taking care of it all. And as we mentioned, take care of you is important, helps prevent burnout. And how do you take care of yourself? Why to do it, prevent burnout, set limits, and pace yourself. Don't need to go 100 miles per hour every step of the way. Just try your best to control your stress and situation. And as we mentioned earlier, taking care of yourself so you can take care of others. And if it's something that, you're overwhelmed or too much, it's okay to ask for help and see if others can help, and see if your community or other family members could help in the care. And that underscores the importance of groups like Cancer Support Community. Another set of people in another community is going through what you're going through, so they can relate to the struggles you have. Talked about in earlier counseling, and then finding help within your community, specifically religious as well. All right. Let's do that real quick. And community resources. As you can see, Cancer Support Community website there, cscatlanta.org. Then another great national organization who I've worked with in the past is BCAN, the Bladder Cancer Advocacy Network. I trained in Oklahoma. When we were in Oklahoma, they usually had a BCAN run for bladder cancer every year. I don't know, I haven't had a chance with life and two young boys to look into it here, but that'd be something to look into. They always do have a lot of resources and events from BCAN and of course Cancer Support Community Atlanta. All right, if you are looking for me, I'm georgiaurology.com. If you're social media or social media, if you like social media, we are on all the different types of social media, GA Urology on Twitter, Facebook, LinkedIn, pretty much everything, Instagram. And then if you're looking for Dr. Chowdhary, she's with Atlanta Cancer Care, simple enough, atlantacancercare.com. So I think I'm doing okay with time. I think we got about 10, 15 minutes for questions, concerns, and then some of our sponsors here. Thank you so much for your time. I appreciate it. You spending a lunch with me and Dr. Chowdhary, and hopefully this was informative for you.
Thank you, Dr. Mellis. So we actually do have quite a few questions that have come in while you were giving that very thorough, informative talk. I'm happy to tag team with you. I know some of these questions are a little bit more oncology directed. So one of the first questions we got from a patient or a participant is, can you talk about post-surgery recovery after cystectomy? What can patients expect in terms of timeline and symptoms and that sort of thing?
Yeah, no, that's a great question. I will preface that with I haven't done a cystectomy in a while. We do have. I've taken care of plenty of cystectomies and did quite a few when I was in fellowship and residency. I would say we do have a partner down at Northside in Atlanta who does the lion's share of the cystectomies for our group of Georgia Urology. So he does them robotically. So typically those are somewhere between 5 and 7 incisions, where the urostomy is taken through one of the incisions. Anytime there's surgery, there's risk, right? Infection, bleeding, pain. It's going to require pain medicine for several days, and risk of anesthesia. I mentioned usually about a 5 to 7 day stay in the hospital on average, and then a full recovery usually about 8 to 12 weeks. You're not bedridden for 8 to 12 weeks, but you're in the limit the amount of what you can limit your activity to a degree. Your physical exercise as everything heals up. One of the things that makes a cystectomy, I'd say, a little more difficult is not necessarily the bladder removal portion of the procedure. It's the fashioning of the incontinent diversion, that is the urostomy or the neobladder. So you're taking this piece of intestine, which is this large contiguous area. You're actually taking about a 5 to 6 inch segment of it to sort of use as your urostomy, and then you have to basically disconnect it from the bowel, and then reconnect the two ends that you were that you harvested from back together. So usually we do see patients some complications of a term what we call ileus, where with all the bowel manipulation and the anesthesia and narcotics, the bowels can sort of be slow to wake up, and that can cause a lot of abdominal pain and discomfort. So that is something we do see. And then there are some electrolyte changes where sometimes patients we see after cystectomy do require readmission because they're dehydrated and do require volume intravenous fluids and other forms of volume.
So we're kind of, I think, what you're alluding to is probably around that 3-month mark, assuming no complications, patients should be able to get back to normal life or their new normal life.
Correct.
Yeah. So similarly, another question relating to, I guess, surgery and systemic therapy, which I can talk about. Are there any bladder cancer treatments that affect fertility? I guess maybe if you want to, yeah, go ahead.
I'm trying to, usually, so the transurethral resection of a bladder tumor should not affect fertility. Cystectomy in men, to be frank, this does occur usually later in life. Cystectomy in men usually does involve removing the prostate as well. So typically with removal of the prostate and then the organs behind it, so typically also be a removal of the seminal vesicles and then a vasectomy as well. So that obviously you can imagine if you've had a vasectomy and then the prostate and the seminal vesicle produce that ejaculate fluid that helps nourish a man's sperm, then yes, infertility is to be expected. As for just a standard sort of just removing the bladder tumor, that typically should not affect fertility. As for more systemic therapy like chemo or immunotherapy, I'd have to defer to Dr. Chowdhary there.
Yeah. So Chemotherapy definitely has an impact on both female and male fertility. So a lot of times in our unfortunately younger patients who have cancer, we do send them to a fertility specialist, and we'll have have them do sperm banking before starting chemotherapy. So I think, if there's a situation where somebody needs to have neoadjuvant chemotherapy, which is chemotherapy prior to surgery, that would be a good time to go and see a fertility specialist before we even begin any sort of intensive treatment. That was a good question.
I'll also comment on the cystectomy. In women, we typically also, as part of a cystectomy, just because of local invasion of cancer to other organs, would also usually do a hysterectomy, removal of the uterus. So yes, I would say cystectomy would definitely cause infertility. Sort of the like a bladder tumor resection, or a lot of the in-house treatments like BCG usually do not.
Great. So another question we're getting is, can you discuss the advantages of doing chemotherapy before surgery?
I'm gonna kick that back to you.
So I think in a lot of cancer types, not just bladder cancer, there is this sort of new way of treatment where we're doing chemotherapy prior to any sort of surgery. And the reason, most of the time, the reason that's done is so that we can shrink the tumor, have better surgical outcomes, ensure that margins are negative. And it also gives us a sense of how responsive the cancer is to chemotherapy. So we'll be able to get a sense of how much did this cancer actually shrink. But I think primarily the goal is these are early stage patients, and we're trying to get a cure. And so giving them some sort of systemic therapy prior to surgery hopefully increases chance of cure.
Agreed. And I know in bladder specifically, neoadjuvant chemotherapy, or once again chemo before surgery, has been proven to increase overall survival.
Yeah. Great. Another participant question: I'm going to reword this a little bit. So I think what they're trying to ask is like breast cancer, does bladder cancer also metastasize? And are there any signs and symptoms we should monitor for in this regard?
Yes, there is. Unfortunately, bladder cancer can metastasize. Usually to the lymph node, bone, and bone and other internal organs. Signs that you can see, that's some of the signs we saw in the presentation. That's where the fevers, the weight loss, the bone pain can come into play, and that kind of underscores, typically patients who have bladder cancer, I would say at least on an annual basis, depending on the aggressivity of the disease, we do imaging, whether it's in the form of CT scans, PET scans. So absolutely, unfortunately, bladder cancer, like all the other cancers, doesn't play fair, and we have to make sure we keep an eye on it.
Yeah, I agree with echo everything you just said. Bladder cancer, mostly we see metastasizes to bone, liver, lung, and so when patients are being surveilled and we're following them routinely at appointments, we do check blood work, and we monitor for those types of symptoms. And so I think patients on their end, what they need to look out for is anything new and abnormal that isn't improving on its own. So I think any sort of pain or discomfort that's unusual should be brought up to your physician.
Agreed. Yes.
So I think this is a patient-specific question, if you feel comfortable answering. So this is an elderly patient who had a tumor removed from his bladder in February. Pathology showed it as an inverted urothelial papilloma.
Mm-hmm.
And he had a follow-up cystoscope, which showed a new small tumor, which they, again, want to remove. They want to resect. The question is, what are the risks of removing this, or would it be okay to wait? Is this something that may become invasive?
Yeah, I think if there is something that is new, I always do recommend removal. What are the risks of removal? Once again, general surgical risk, infection, bleeding, pain, anesthesia, burning, possibility of a catheter when you wake up. But just because it was a inverted papilloma, which it's been a while since I've looked that one up, but I think it's either non-aggressive or non-cancerous at all. But just because it was inverted papilloma last time doesn't necessarily guarantee this one will be. This tumor, whatever it may be, would be the same thing. So it could be cancer, and I guess that's always the concern. Is even with the most non-aggressive cancers, you always want them to be removed to avoid progression or recurrence.
Yeah, I would agree with that. So another question I commonly get from patients that come into my office are, when somebody gets a diagnosis of cancer, whether it's bladder cancer or some other tumor site, they will always say, why did I get this? What caused it? So I don't know if you can touch upon some of the risk factors for bladder cancer and maybe things people can do now to decrease their risk of getting cancer.
Yeah, no, that's a great question. One of the risk factors, as we get older, unfortunately, our risk of cancer increases. But I would say the number one risk factor for bladder cancer is smoking. Just put down the cigarettes. Other things, certain occupational exposures or folks who are like chemicals like painters, hairdressers, folks who work some chemicals. But the absolute number one risk factor that what can I change to make my life better is if you're a smoker, stop. That's everyone says, smoking causes lung cancer, but smoking causes just so many different types of cancer or increased risks, specifically in the genitourinary world, bladder, kidney, prostate. So the first thing, if you're a smoker, stop. And those things we talked about, be healthy lifestyle, try not to be good weight, exercise regularly and eat well the best you can. And I think that'd be a good place to start.
Yeah. No, I agree. I think number one is definitely smoking, and like you mentioned, exposure to chemicals and pesticides and benzenes and that sort of thing. One of the patient questions that we received is: do frequent UTIs increase risk of bladder cancer? Our patients are at higher risk.
Yes. So that's something. If that may be something. What I routinely do in some of my patients, especially those who I see who have chronic UTIs or recurrent UTIs, is I usually would, part of my evaluation after sort of trying to do some supportive non-invasive measures would be to do a cystoscopy. Cystoscopy is where I put a little catheter inside the bladder after we numb up the urethra, the urinary channel, and we take a look inside the bladder to make sure nothing out of the ordinary, like a tumor or a bladder stone. But yes, I typically, folks with recurrent UTIs after sort of, or especially risk factors for, in addition to recurrent UTIs, I typically would probably do cystoscopy on.
Okay. Yeah. And then there were a couple of more oncology-directed questions, and feel free to chime in.
Sure.
Someone was a participant asks, what would make me a good candidate for targeted therapy? So in later stage bladder cancer, so those that are unresectable or have metastasized, standard of care is usually some sort of a platinum-based chemotherapy, but not everyone is able to tolerate that due to pre-existing kidney disease or neuropathy or whatever it may be. And so immunotherapy is coming more into the forefront, and it's from a side effect perspective, our patients are tolerating immunotherapy much better than chemotherapy. So that is an option, and then we also now in our office start sending off NGS testing, next generation sequencing, which is usually a blood test, or it can be done on the pathology itself, where we're looking for any targets that we could potentially use for treatment. And so, targeted therapy, I don't always do in the frontline setting, but I make sure we have this information up front so that if it does come to a point where they're not able to tolerate chemotherapy or the cancer is growing, regardless of them being on chemotherapy and immunotherapy, then I would jump to something like a targeted agent.
Yeah, I agree.
Yeah.
We do this a little bit more ourselves in prostate cancer,
Mm-hmm.
where people with high risk or metastatic disease, we pretty much reflexively get genetic testing. So I agree.
Yeah, no, I think in all tumor sites, this is kind of coming to the forefront where NGS testing is very, very important. I think that concludes our questions. I can turn it. Oh, actually, I'm sorry. There's one. Another case, which I think, Dr. Mellis, this is for you. So patient was diagnosed with bladder cancer in 2017, had their tumor removed, and they did 6 treatments of BCG and 1 chemo treatment.
Okay.
I'm assuming maybe gemcitabine. Patient says, I've had cystoscopies every year and have been clear ever since. I have not had any blood work or CT scan since 2017. Would you advise a CT scan prior to my next cystoscopy? A very specific one.
Yeah, no, I think there are a few variables, like how aggressive it was. I think that would have to be a conversation with your urologist. I would say probably just to be safe, but I think there are a couple points there. I don't have the entire picture, sorry, but I don't think it would hurt. I
agree. I think so. It sounds like the initial diagnosis was 6 years ago. So maybe at this point in time, so the further removed patients get from their initial diagnosis, the frequency of surveillance and scans also decreases. We aren't scanning as frequently. But I agree, might need to know some more of the specifics, but it sounds like if everything has been clear.
Great sign, obviously.
Right. I think if it sounds like everything's been clear, and so there hasn't really been any reason to do scans, but if there's new symptoms or any abnormality in routine blood work, then yes, I think it probably would be a good idea.
Yeah. Agree.
Yeah. Well, I think that concludes all of our questions. I guess I'll turn it back to you, Katie, if you're able to get on.
Yeah, thank you both. I think that was a great Q&A. Thank you, everybody, for entering such great questions and such an informative presentation. I do want to encourage everyone to please click the link that's in that chat box. It helps us tailor these slides to the information that's most needed to this oncology community. So if you could, please share your thoughts through that link. I want to thank Dr. Mellis, Dr. Chowdhary for being so generous with your time and expertise today. and encourage everyone. Again, a recording of today's program will be sent out, and it'll also be available on our video library, so you can check it out with all the other information on Cancer Support Community Atlanta programs at cscatlanta.org. So thank you again, Dr. Mellis, Dr. Chowdhary, and thank you everyone else. We hope to see you soon. Take care.
For your time. Y'all take care now.
Yes, thank you.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.